Hello and welcome to everyone for joining us for the panel, COVID-19 and the Future of Long-Term Care. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'll be the moderator for today's session. In July, the Royal Society of Canada published a policy briefing called Restoring Trust, COVID-19 and the Future of Long-Term Care, same name as our panel. It was part of a series of policy papers related to the Zero Canada project. Today, we're going to discuss the issues raised by that report and what needs to happen next. The format is pretty straightforward. We'll have a brief overview of the report from a couple of our panelists, then I'll be asking them some questions, and of course, we welcome participation from the audience. The best way to ask me your questions is to put them in the chat box and I'll incorporate them into our discussion. Please remember to keep your mics muted. They should all be muted, but keep them muted so we don't get a lot of background noise. So let me introduce the panelists. Sharon Strauss is a professor at the University of Toronto and a scientist at the Li Ka-shing Institute. She's a geriatrician by training and her specialty is knowledge translation. You can give us a wave, Sharon, so people can see you in the crowd. Thanks. We have with us also Carol Estabrooks. She's an adjunct professor in the Faculty of Nursing at the University of Alberta. Her research focuses on quality of care, quality of life, and quality at the end of life for older adults, especially those living in long-term care. We have with us Shubi Banerjee. He's a professor of dementia and associate dean at Brighton and Sussex Medical School and director of its Center for Dementia Studies. He also works as a geriatric psychiatrist. And by geriatric here, I'm referring to the age of his patients, not his age, of course. He's very young like the rest of us. And we also have with us Roberta Bishop, who's the operations manager at Rainbow Resource Center, which offers support to the two-spirited lesbian, gay, bisexual, trans, and queer community in Winnipeg. She's also a member of the city citizen advisory group Voices. So I'm going to turn over the virtual floor to Sharon, and she'll be joined as well by Carol, and they'll give us a background and some presentation on this report before our discussion. So Sharon, over to you.
Great, thank you so much. I'm going to share my screen. Great, thank you very much for the introduction. Thanks everybody for joining us today. Carol and I are going to take turns presenting an overview of the report. But before I do want to do an acknowledgement of the land on which we're really fortunate to be able to work. And we recognize that this territory has a long history that predates the European colonies, and also acknowledge the territory's significance for the Indigenous peoples who lived and continue to live on it. People whose practices and spiritualities were tied to the land and continue to develop in relationship to the territory and its other inhabitants today. In particular, I'm based in Toronto, which is the land that was home to many Indigenous people, including the Mississaugas of the New Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee. I'm very grateful to be able to have the opportunity to live and to work on this land. Today, it's the meeting place and home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on the land and also recognize that we all have a tremendous responsibility to care for the land that we use. Also want to acknowledge that we are committed to recognize, honor, and take action on the Truth and Reconciliation Commission and the Missing and Murdered Indigenous Women and Girls Inquiry Calls to Action. I wanted to acknowledge the members of the working group who prepared the Royal Society report with Carol and I, and in particular, wanted to highlight the contributions of our reviewers, including Naomi Black, who is a resident of a long-term care home. I also want to acknowledge the residents and staff of the long-term care homes who have been managing during the past few months under tremendously onerous conditions, and we acknowledge their contributions. So for the report that we did, we took an approach where we really wanted to focus on the evidence. And in particular, we reviewed the research context and policy environment in long-term care in Canada before COVID, but also addressing kind of what was unique about COVID that contributed to the crisis that we've seen in long-term care. And we also wanted to use evidence to inform the potential solutions to the challenges within long-term care. We recognize that we didn't address absolutely everything that was relevant to long-term care, nor did it address Indigenous people in long-term care. And we wanted to make sure that, that we recognize that today and acknowledge that, that hopefully in future briefings this will be addressed. One of the things that the report did focus on was really to consider how to use an intersectionality lens in our approach to long-term care homes, and in particular thinking about the evidence that we have to inform our recommendations and how we need to consider all of these aspects when we're implementing these recommendations. I'm going to hand it over now to Carol, who's going to talk a little bit about the origins of nursing homes and then some of the findings from the reports, and then I'll speak to some of the recommendations. Carol?
Great, thanks, Sharon. Good morning, everyone. I see a few familiar faces on the list, so welcome to you too. You'll be pleased to know I'm not going to do a history of nursing homes, but I do want to bookmark that the origins of nursing homes in Canada are not in anything related to the Canada Health Act. They're in 17th century Elizabethan poor law and in the religious charities. And so the original nursing homes, if you will, were like almshouses, poorhouses. They cared for the poor and the homeless, people with mental health conditions. And that history carries through in dribs and drabs into what we see today, and we think is part of the structural problems that we're experiencing in Canada today in long-term care. Next slide, please. There's not a lot to say about this, except that there are decades and decades of reports and media and research studies, and they're all characterized by an unfailing repetition of findings, the majority of which have not been acted on. Next slide. So COVID-19, as you've all heard, did not break or crack or squash or whatever the verb is you want to use the long-term care sector. What it did was act as the proverbial straw that broke the camel's back and illustrated how deep the long-standing systemic and structural problems are, not just in Canada, but internationally. And in Canada, the extent and almost a metaphor for that is that over 80% of COVID deaths that have happened in Canada have been in nursing homes or care homes. And that's the highest rate of any country globally. So it's a blemish on a record of a high quality of life, high income country. Next slide. The root causes are many. I'll talk about just a few of them, but I want to point out, because you hear a lot about financing and jurisdictional issues in a foggy, confused regulatory environment. Sharon's mentioned inequalities and inequities. There's generally a view among people in the industry and among most people working there that these are homes, not institutions, but that isn't always carried out in how we approach the care that's required. We don't place a lot of value on caregiving, and that's partly because caregiving is largely the domain of women, especially in long-term care. And the COVID pandemic has had a disproportionate impact on a lot of people, and certainly on women. 2/3 of people with dementia are women, 2/3 of residents in care homes are women, 90% of the care staff are women, 75% of unpaid caregivers are women, so it's a huge impact on women. And we talk about that, but we haven't seen policy changes that reflect solutions. And we think, I thought on the panel, that at the foundation of it all is this inability to see ourselves as old and with dementia and approaching death. And if we're unable to think of, or we choose not to think of that, is probably the case, it's hard to have a thoughtful national or regional conversation about who it is that's in nursing homes. We have put older adults in Canada in nursing homes with good intention, I believe, but it has created an out of sight, out of mind silencing of this group. They're highly vulnerable. And they don't have much voice, in part because of the disease condition that puts them there, and in large part that's dementia. And so we don't see them and we close the doors, and sometimes we think comfortably that everything will be okay because there is a system that's well suited to manage their needs. Next slide. So COVID-19 has been unique. It's new. We haven't had population immunity. It's highly infectious, and there hasn't been to date an effective treatment or prevention, certainly not any effective treatment that's available to older adults in long-term care. It happened in a population of older adults with less competent immune systems, with dementia and communication difficulties, and often presenting with atypical symptoms. So it was the kind of communicable disease that was particularly suited, if you want to think of it that way, to thrive in areas like long-term care. Not just long-term care, other areas where people are congregated, like prisons, have also had a disproportionate impact. Next slide. So I'm not going to belabor these, just to mark them and maybe point out in particular the third one, which is that there's no national framework in Canada that's similar to the Canada Health Act. We're not necessarily and not really advocating for adding long-term care to the Canada Health Act, but we do think that we did recommend that we need to establish a national framework with which to manage long-term care in the country, so that we have some of the pillars that are in the Canada Health Act, so that analogous pillars exist in a national framework. And we saw in the throne speech in September a call for national standards, and immediately thereupon a lot of provincial and federal squabbling about jurisdictional issues. So hopefully we can resolve those and move to this kind of a framework. Next slide. You all probably know this, many nursing homes are old. And these group settings often have more than 2 residents in a room. And that varies by province quite dramatically. So BC has a high proportion of single rooms, in Alberta quite a high proportion, but in Ontario you see many more 2 and 4 bed rooms in nursing homes. There's a fairly serious lack of integration across the entire system, certainly between acute care and other parts of the continuing care system. And when that happens and everybody's acting in a silo, then it's really hard to have an effective response to a pandemic, because everything you do in a hospital with older adults affects some other part of the system. And so integration has been and continues to be a major issue with which we're struggling. There's an appalling and shameful lack of data with which to manage the system. If you don't have good data, you can't really manage a system well. And as equally as problematic is the data is only half the battle. And if you have good data, but there's not a system built to act on it, it isn't effective. People aren't, we didn't spring form fully formed from the loins of Mother Earth, able to act on data to make change. It's a skill and it's a learned activity. And we haven't got supports in the system to support the people managing the system on the front lines to use the data, to get the data we do have to them in a usable way, and help them with using it to promote change and sustain that change. So these are 2 big challenges in the continuing care system. Next slide. We've seen a general decline of regulated staff. We have a direct care workforce that's poorly trained, older, racialized, poorly remunerated, and about 1/3 of them pre-pandemic worked more than 1 job. And of those, about 70% were doing that for financial reasons. This vulnerable population is caring for an even more vulnerable, socially and medically vulnerable and complex population of older adults. They're very old. They have a lot of cognitive impairment, highly dependent. And because they come to nursing homes later, because we're being more successful with community supports and home care, not perfect, but more successful, they're closer to death and need a strong palliative approach to care and a strong supportive approach to ensuring that we can support quality of life for people in the last stage of their life, even with moderate to severe dementia. That's possible. Not everybody in the country is on that page, but certainly people who are working in the industry are. And this vulnerable population, looking after an even more vulnerable population, has been a perfect storm that's been brewing for decades. And COVID has brought it to light in really unfortunate ways. Next slide.
So
turn it back over to Sharon now.
Thanks so much, Carol. And I'm just going to focus briefly on some of the actions and next steps that we recommended in the report. And I don't think any of them are going to be very surprising to you based on what you've heard from Carol. In particular, one of the key things, and Carol mentioned this, is around ensuring that there is appropriate pay and benefits for individuals who are working in long-term care homes. And as you know, that there is a big disparity in wages between acute and long-term care, and this needs to be addressed. Also ensuring that people do have access to sick leave, because if they are required to be in quarantine, it's difficult if you don't have sick pay. Other resources to support those required to quarantine include things like access to being able to get food and prescriptions and things like that. So really making sure that people can adhere to quarantine. Looking at opportunities for full-time employment. So rather than somebody having to work in multiple places part-time, facilitating full-time employment opportunities. Carol also alluded to us really needing to look at the one-home policy. Other things that were identified is really making sure that we think about the educational standards for PSWs and care aides, and not just kind of having one-off education, but continuing education. And certainly that's something that we can see during the different waves of the pandemic and how guidance has changed over time. And so the need to be able to provide ongoing education and training for staff. One of the biggest things that we need to address is providing mental health support for the staff in long-term care. And this is something that needs to be addressed now and also in the future once the pandemic is over. These individuals have experienced profound tragedies and moral distress, and PTSD is a challenge that they will be facing. Carol also mentioned the need to have national standards, and in particular thinking about national standards for staffing and the staffing mix. And so the relevant numbers of different types of care personnel who are going to provide direct care in nursing homes. Also thinking about the standards with regards to infection prevention and control. And again, this seems to be quite variable across the country within each province and territory. And we need to think about what this should look like. It was also mentioned around protocols for expanding staff, but also thinking about how to bring patients or bring family members into the mix so that they can be involved with providing care for the residents in long-term care homes, and that they would receive the appropriate access to PPE and training with regards to providing personal care to residents in that context. Also thinking about being able to measure outcomes, and Carol mentioned that we can't really manage without measuring, and we really do have a lack of data, and so we need to have data on quality of care and quality of life for the residents, but also thinking about the families and their essential care partners and their experiences, and the quality of work life of the staff who are in the long-term care homes, and how can we measure and monitor that over time. We also suggested that the province and territories need to collect data at arm's length from the long-term care home sector, and that this really needs to be evidence-based, and that we need to be looking at relevant quality indicators, that then we have a formal accreditation process with regulation and inspection where there is accountability. So in terms of the next steps, it's really managing the second wave and hopefully preventing subsequent waves, and really making sure that we stop blaming and shaming the frontline workers in long-term care homes. I was saying that in the past few weeks, I've heard lots of different pejorative terms, such as calling PSWs infectious vectors. And we really need to step away from this and support them and provide them with the resources that they need at the front lines. Within the long-term care homes, we need plans for infection control, including how to cohort people in these older buildings, how to do line listing. We need access to rapid testing. These are things that are going to allow us to manage and prevent outbreaks. Similarly, thinking about the supply chains for things. So not just the supply chains for access to testing, but also for PPE. And as both Carol and I have mentioned, enabling the family and the essential care partners to have meaningful contact with the residents and to be able to provide care, personal care to the residents. We would like to see a commission, a national commission, and national standards for long-term care homes that include the staffing features that we've talked about, and that there needs to be collaboration between the federal, provincial, and territorial governments on the recommendations, in particular around the workforce crisis in long-term care. We also have to think about how we can optimize long-term care over the next few years and really think about innovation, scaling up, and ultimately evaluating as well to make sure that what we're doing is achieving the outcomes that the residents, their families, and all the stakeholders want to see. Thank you very much, and I'll hand it back to Andre.
Great, thank you very much, Carol and Sharon, for that introduction. And I've posted a link to the full report in the chat function. So everyone who wants a copy of the report, it's available there. Now, Shubhe, I wondered if I could start with you. We've heard this very depressing background about all the things that are wrong, how they've been long-standing problems, but I want to bring it right into the present with COVID-19. Now, we heard in that presentation, older people have been disproportionately affected by this pandemic. And I guess the question I want to ask you is, did it have to be like this? Was all this inevitable?
It didn't have to be like this, but I think that the reasons why we have got to where we are, which the last two speakers have been talking about, are hardwired into decisions that have been made over the past decades, rather than ones that are just ones that we've made recently, though they've been exacerbated by decisions that were made in the last year as well about COVID. So what do I mean by that? Well, I think there are two bits to that. The first thing, in terms of the more distal reasons, the things that have been a problem for many years, I think that the story that you have told for Canada is a story that you could tell for almost every higher income country in the world. And it is, for me, a story that fundamentally is about valuing older people and people with dementia, who are essentially the residents of care homes. It's about valuing older people and people with dementia lower than you value other people. So the systematic discrimination that exists between the amount of money, for example, that is expected to go into the health system in almost every developed country, and the money that goes into the long-term care or social care system, it's disproportionately different, those two things. I think that it's an exemplar of fundamental ingrained decisions that have been made over years and years and years that are fundamentally based on the idea that an older person's life is worth less than other individuals' life. And in particular, when people are old and frail and have dementia, their lives are worth less. And therefore, it is not reasonable to spend as much as you would on long-term care as it is on acute care. So I think that's the distal region. It's one of institutional ageism and its effect on service provision and service funding, and also the political will to change things. The second thing more recently, I think, is that, again, really, wherever you go in the developed world, and it may well be that Canada has a particular issue in terms of the high mortality within long-term care facilities, or the higher mortality, but wherever you go in higher income countries, there has been very high mortality within long-term care facilities. And I'll speak more from the UK viewpoint because I know more about what has happened and the choices that were made. But essentially, people in long-term care facilities were discharged more quickly from general hospitals. There were less controls on them on them getting COVID, and they were given worse treatment within general hospitals in many ways. So that what happened was that individuals with COVID were reintroduced into care homes, and they became very clear that that was a very fertile place for the disease to spread. And so what you had was that you had older people and people with dementia essentially being sacrificed for the benefit of general hospitals. The real concern in the UK was that the general hospitals would be overwhelmed, intensive care units would be overwhelmed. And so there was a real desire to not admit people with COVID from care homes, and also to discharge quickly individuals from general hospitals back into care homes. And that directly led to the disproportionate mortality within care homes in the United Kingdom. Now, there'll be similar processes wherever you go, but essentially that boils down to an idea that there is less value to be accorded to those individuals than the individuals that are and were treated within the general hospitals. Perhaps I could finish with a comment that comes from what Carol mentioned. Carol mentioned, I think, that the care home system in Canada, and it's absolutely true, it's the care home system in the United Kingdom as well, is based upon Elizabethan poor laws. Essentially, Elizabethan poor laws created the concept that there were the deserving poor who could be helped and the undeserving poor who essentially would receive no help at all, people who, you know, who were less deserving than the other ones. I think that what we have seen in COVID is the creation of a deserving ill class, young, fit, well individuals, people who are able to articulate for themselves, perhaps, they're deserving well, and an undeserving, sorry, a deserving ill and an undeserving ill population. And the long-term care population have been the undeserving ill who, through our attitudes and behaviours, have been denied treatments and denied protection and support that might have enabled them to live better and have better outcomes. So I think that that we still have the concepts of the Elizabethan poor laws at play in creating the problems that we find across long-term care, across high-income countries.
Great. We'll come back and we'll discuss some of these issues of systematic ageism and neglect as we go along. But I want to bring Roberta into the conversation. Now, Roberta, we heard in all these comments so far, this theme of, you know, older people are out of sight, out of mind, they're systematically discriminated against. Now, this is something you're familiar with in the LGBTQ2S community. Can you talk about a little bit about the importance of being seen, of being heard to bring about policy change? I think you're still muted.
Thank you. My apologies. I think that some of the things that are so critical to remember for our community members is that for many, although we report 3% of the population do self-identify as 2S LGBTQ+, in realities are probably closer to 10 to 14%. But accessing care often brings about the threat of having to out oneself, and especially in the older population and a number of older adults who are not yet comfortable in coming out. That's one of the tragedies that will delay accessing of medical services. Also, the fear of not having the family of choice recognized as being people who can participate. Here in Manitoba now, it's real lockdown, of course, and they're still struggling, but we've sort of self-identified that you can identify one member of the family who can come and be in contact. But there are still institutions out there who assume that families are identified by blood relationships. I'm not sure if that answers the question, if that provides some additional information. The other piece that's always, I believe and have experienced in discussions with some community members, the tragedy of the current COVID-19 pandemic brings back for many the tragedy of the AIDS crisis in the 80s and 90s. And for those of the population who are experiencing dementia and revert back to that time in their lives of 40 years ago, seeing all the PPE coming towards them adds further confusion to dealing with the current realities. And those are some of the things that we need to educate the caregivers, educate administrators, educate managers, and educate other people in the care home situation and the community at large.
Yeah, it's a good reminder. There's a lot of traumas underlying what's going on now, and we'll hopefully come back to that again later as well. So Sharon, I want to come back to you. You know, in the presentation, in the report, there's a lot of emphasis on fixing the workforce issues. So I want to, is it fair to say that you can't have good care without a decent work environment? Is that the essential message that's being delivered in the report?
So absolutely, it's about making sure that we have an adequate workforce in terms of the numbers and the mix, that they're paid appropriately so that they should receive the same salary as if they were in an acute care setting. And that they have the adequate training and support. So the adequate training around infection prevention and control and reminders on an ongoing basis, that they have adequate support around mental health and how to deal with this, with the pandemic and on an ongoing basis. So it's really about making sure that we have the adequate workforce. And then it's also thinking about the model of care itself within the long-term care home. And so being able to have access to direct care providers, but you know, we also need to think about the indirect care providers. So laundry services, nutrition services, environmental services. You know, these are individuals who are also on the front line of the pandemic, and their needs to be addressed as well and need to be supported. And we need adequate numbers of these individuals within the long-term care setting. And then also thinking about, from the clinical side of things, ensuring that there is access to adequate primary care clinicians. So making sure that residents have adequate access, and then whatever specialty physicians might be required. And then also access to the multidisciplinary team. So thinking about things like dentists, physiotherapy, occupational therapy, speech and language, spiritual care. All of those components require resources.
But haven't we been talking about this stuff for decades? You know, will it actually change now because of the pandemic? Do you have some hope there?
So you're absolutely right. We've been talking about it for decades, and I think this is the thing that, you know, many of us on the panel find really quite distressing. That we talked about it for decades. People have been writing about it for decades. So Carol and I have two graduate students, Trina and Eric, who led us on a study recently looking at, you know, there's about 80 reports that have been done in the last 22 years on long-term care that have cost tens of millions of dollars. And if you look at the recommendations that come out of those reports, the bulk of them are exactly the same. And yet Ontario has commissioned recently yet another commission that will probably find the same recommendations and the same challenges. And so, you know, what we need to do is move away from studying it and doing another commission or another inquiry and implementing the recommendations. And if the pandemic isn't sufficient to implement and to cause that change, I don't know what more, you know, is needed. I don't know, Carol, if you wanted to add to that.
Only to say that just because we're very hopeful, and we should be, about the number of vaccines that are on the horizon, our politicians shouldn't use that as a reason to think they can take their foot off the pedal in terms of what needs to be done in long-term care, because this is historically what's happened. There's a crisis, often usually smaller than what we have now, and there's a big media display and a bunch of inquiries, and by the time the inquiries reports come out, things have settled down and the political agenda has changed. This is about core values. And Canada, it's not just the politicians, we always blame the politicians, unless the citizens of Canada will engage in a discussion and insist that an old person has as much value, a life lived has as much value as one that's going to be lived. I don't think we're going to see change. We have to insist that our siblings and spouses and parents and grandparents and long-term companions get the care and support, both health and social, that they need and most of us believe deserve.
Now, Carol, the Royal Society report, it actually says that we need a moratorium on panels and on reports. Can you address that? And it may seem a bit ironic because we're in a panel discussion discussing a report, but talk about the need to just stop doing this stuff over and over again.
I think that was probably one of the most disheartening pieces of doing the report is we assembled all these reports and went through them and came to the conclusion that the last thing we need is yet another commission. Yet almost every province has had or is in the process of making a commission. And we haven't seen a federal one yet, but stay tuned. We need an act like, this is not a good analogy, but some countries have a space force. Well, we need an action force. We need to have a group tasked with acting, who've got the levers of change and power and policy, and broadly engaged, not just the professionals, but the residents in the nursing home. So you can talk to, even with dementia, and their family and friend caregivers, and really look at what does it mean if a care home is supposed to be like a home, and look at some of the models that we say, oh, well, that's really nice for the Netherlands or wherever we find the model, but we couldn't do it here. It'll bankrupt the country. We can make changes even in our miserable old buildings that have to do with the conditions of work, which, as Pat Armstrong at York would say, are the conditions of care, have to do with relational care, have to do with creating an environment where when you get up in the morning, even if you're old with bad dementia, you have some reason to get up. There's some joy in your day. You taste things, you smell things, you see people of different ages, you laugh, and you're not in pain, and you don't have pressure ulcers. But the quality of care stuff is important, but it's really in the service of quality of life. We have to really take a look at risk. We're so risk averse in nursing homes. Like, we have 70% of people in Canadian nursing homes in wheelchairs, in no small part because, we can't let anybody fall. Well, we could put compliant flooring in all the nursing homes, and it would cost some money, but it would help reduce injuries from falls. And there are other things we could do, because moving and walking is a human thing that we do that makes us feel better, and it's really good for our health. So there's, I don't think we need another commission to tell us what the problem is. We know what the problems are. We need to act on it and create a way to have a federal, I don't know, this might be overly optimistic, but federal provincial cooperation, and stop squabbling about whose jurisdiction it is. I don't think that any of the people who died in wave 1 in Quebec homes where the military went in, or Ontario homes, from dehydration and starvation in their own excrement, worried about whose jurisdiction it was. And if we could just get by those jurisdictional issues, I think these are all solvable problems. We have the resources. We're a wealthy country. We could make a difference to older adults, and just so that we all remember, make a difference to ourselves, because however long it's going to take everybody on the panel, we're all going to get there. So.
And as one of the people said in the chat, said we have to walk the walk and not just talk the talk anymore. So I think that's a good summary. Shubé, I want to come back to some stuff you said earlier about, the disposability of older people. Why do we have this attitude? I can't tell how many times I hear, well, they were going to die anyhow. The Barrington Declaration is essentially the foundation of it is, well, lock the old people away. They don't matter as much as the economy. Why do we have these lingering attitudes, especially in an aging society?
It is weird, isn't it, given the fact that higher income countries are aging quite as quickly as they are, and given that everybody has parents out there, it is very strange. And I think that the only way to understand the fact that everywhere in the world there have been these crises in long-term care, and there has been a similar inaction also in most places in the world, is because of it being an unconscious bias rather than a conscious bias. These negative attitudes towards old age are profoundly and deeply burnt into society, and it takes real effort to unlearn the things that you believe. So it is absolutely true that and that you believe without even knowing that you believe them, so you're acting on them. And so, for example, there is an absolute belief out there that that life is worse when you are old than when you are young, and there is no evidence to suggest that that is the case. Older people can have just as good a quality of life as younger people. They adapt to the problems that they have. Human beings are marvelous and wonderful machines that are all about adaptation. And people believe that people with dementia cannot have a good quality of life, and that necessarily, because of the progressive nature of dementia, your quality of life must go down and down and down year after year after year. And a lot of my research has been into the quality of life of people with dementia, and again, there is absolutely no evidence that that is the case. People with severe dementia can and do live good, fulfilling lives, and they live those lives at home, supported by their families, and they live them in good care homes as well, supported by paid carers, doing all the things that Carol have said that enables people to live well. And I think the minute you realise that everybody, that people who are old and people who are frail and people with dementia can live good lives as long as they are supported appropriately, then the question has to be, is it worth the money? Is it possible to enable people to live well? And I think that, again, one of the beliefs that people have is that it would be ruinously expensive to provide long-term care that would enable people to live well. And that is not proven. And as far as I can see, again, looking at the evidence, it's just not true. It does require extra investment. It requires extra attention. But but it is the case that if you look at the amount of money that's spent on long-term care across the developed world, it is gigantically high and increasing. We are spending a lot of money on things that are of a poor quality. What we need to do is to spend a little bit more money and ensure that the things that we do are of high quality. And for me, it comes back to what Carol was saying earlier, that it really is about focusing on the purpose of long-term care being to enable people with complicated and difficult problems, but to enable people to live well with those conditions, to enable people to live with good life quality. So it's not just about safety and keeping everyone in a wheelchair, because that actually creates poor life quality for many individuals. And it's not just about quality of care, ensuring that, that the meals are given on time and that the medicines are given out safely and at the right times. It's not just about that, though that's on the pathway. It's about understanding what makes for good quality of life and then enabling that to happen for people at scale in long-term care facilities. So why is it happening? It's happening because there is unconscious, societal and political bias against this group. And it's happening because there hasn't yet been the political will to do the complicated things that are needed to make the changes that are actually simple things. So people say, well, we don't know what to do. Actually, we do. There are an infinite number of things that you can do to enable places to be homely, that enable people to have good working lives as paid carers, and that enable individuals to make choices and to be supported in ways that that enable them to thrive from, right from the beginning of frailty right through to the end of life. So it's actually about will. We need the will to act, and if we have the will to act, there's so much that we could do, next month and the month after, and in 6 months' time, and in 2 years, and a year's time, 2 years' time, to generate, long-term care that truly cares for our older people rather than simply forgets them.
Yeah, so we do have to pay a lot more attention to the quality of life, that's for sure. Now, Roberta, I want to come back again to, for those of us who've been writing and interested in this field for a long time, there's a lot of parallels in the response to COVID and the response to AIDS decades ago. Can you talk a little bit about, this people being treated as disposable and not important and marginal? Can you talk about how we have to address those things regardless of whether it's COVID or anything else? Well, I don't know if others have had the problem with their screen that I just got, but
Yeah, so I think all of a sudden we saw somebody's slides come up.
yeah, somebody's slides from something else is coming up, but we'll get dealt with that. Can you still hear us, Roberta? Can you still weigh in?
Yes, I can still hear you.
Yeah.
Hello. Yes.
We'll just watch.
Yeah. Hello again. The question again, Andre, is in regards to how we can help recognize the disparities, is it?
Yeah, how are these issues important broadly beyond, whether it's LGBTQ2S or older people? These are issues that are universal, this neglect and marginalizing of people. And I'm wondering how we can address that more broadly.
I think that how we address it more broadly is following up a lot on what's been reported already in the report, of course, and it's also doing our own little bit that we can in our own immediate circles in our own lives. When we take a look at the entire system, it's just huge and it's overwhelming and it's just unimaginable. But if we can make a difference within our own lives, and if there are couple of old fellows down the road that and people are whispering as to whether they are brothers or father son or who, it doesn't matter. We need to extend a hand of inclusivity and awareness and support. And that's the one thing that is coming back to all, is that each one of us can make our own difference. The disparities and the marginalization, I think, are being felt acutely within our community, within the community of the homeless folks who are homeless. I really liked what Sube said earlier about the deserving ill and the undeserving ill. And I think that echoes very, very clearly for us too. There's a great deal of intersectionality in many of the populations, and we just need to continue to support on a personal level as well as on a professional level.
Now, Sharon, I guess the big question in all this is what is the impediment to acting? Why haven't we done this? Shube talked a bit about the lack of political will. Is that what it is?
I think that's part of it. I think that sometimes what happens is that there's this tremendous inertia, and that we get all excited about it, and then all of a sudden we move on to the next thing. And as Carol mentioned, there's a lot of challenges between the federal and provincial territorial governments, and getting rid of those barriers. And so that's probably one of the biggest barriers, is to think about how do we eliminate that and get them to collaborate on the implementation, because it needs to happen in partnership. It can't be done in isolation, and so we do need that partnership. Changing behavior is tough, right? Like anybody who's tried to change behavior realizes how tough it is, whether that's at an individual level when we're trying to exercise or whatever. We know how tough it is to change behavior. So when we're thinking about implementing recommendations like this, across the country, it is going to take tremendous effort, tremendous coordination, but it's doable, and we can do it. We can absolutely do it, and we must do it.
Well, surely we care more about our grandmothers than we care about jurisdictional issues. I would hope we could overcome those.
I would hope so as well. I would absolutely agree with you on that. And I just wanted to add as well, if I could go back to one of the comments that Roberta and Shube mentioned as well around, we've been talking about, is this a factor around ageism? It's age and race involved as well when we're thinking about the long-term care workforce in particular, because if you look at our long-term care workforce, they're older than the median workforce across Canada. They also tend to be, they're largely women, and they're largely racialized. So again, Roberta mentioned the importance of intersectionality when we're thinking about the residents in long-term care. It's also a critical factor when we're thinking about the long-term care staff. And in particular, I think it highlights one of the reasons why maybe this issue has been ignored to a large extent as well. So I think that's another aspect that we need to think about.
And Carol, a lot of people are angry with what's going on, what happened in homes, the carnage there. How do we mobilize that rage to action?
Yeah, good question. I'm angry too. And I get this question a lot. So one of the, if you think back to the AIDS crisis, one of the things that happened was the incredible mobilization of gay white men. And they were young, and they were dying at young ages, and they were earning money and paying taxes. And so we shouldn't forget that. But they were able to mobilize and create action and change. And you see that in other kind of disease groups, if you will. But with older adults in long-term care, who is the group to mobilize? We have a huge number of Canadians and others in other developed countries who are older, the boomers in particular, who are a generation that wishes to have a different kind of old age than their parents and their grandparents. The question is, how do we mobilize the boomers? How do we mobilize the people just behind them? And I don't know, I've thought about this a lot. If you had said to my mom, who would have cared a lot about this, you know, go out and do action, and she would have gone, well, like what? I think we have to show people how to act, how to write letters, how to organize their women's institutes and their legions and the different community groups that we have. I think we also need advocacy at national and provincial levels from places like Alzheimer's societies and the Canadian Association for Retired Persons and other groups. There are citizen groups in this country, like the Imagine group in Alberta, or hosted in Alberta. There are lots of groups, but how do you get the word to them? How do you create? And I think it's going to take some national leadership, not necessarily of politicians, but people got to know how. And I don't think it's fair. Well, my bias is that it's hard to ask families, current family caregivers and just recent family caregivers, because they're tired and they're exhausted and they're approaching really worrisome levels of burnout. If you've ever had a parent you've tried to care for, or a spouse, either at home or in a care home, it's hard and emotionally draining work. And you may become an advocate, but you may not be able to for a while. So we have to figure out advocacy. And I really think, I mean, I've seen provincial governments brought to their knees by proposals they wanted to implement, and the seniors in the province rose up. So I know how powerful that block can be, but it's how do we mobilize them? Because it isn't in their face all the time. Nursing homes tend to be on the fringes of our daily existence, and you can drive by one 100 times in your community, and unless you have some reason to go in, you have no idea of what's there. So that's a bit of a general vague answer, but it's an amorphous problem. It's not a crisp problem where we can say do A and B, and these sorts of advocacy issues will be resolved.
Right. We only have a few minutes left, so I want to ask each of you, I'd like to always finish panels on a semi-hopeful note, if not hopeful. I want to ask each of you, what gives you hope going forward that we can solve this stuff? Shubhe, do you want to kick us off? Do you have some hope that we're going to finally deal with these issues?
Yes, of course, I have hope, and I think that, I mean, in many ways, the world has changed in terms of its understanding of dementia, for example. If we look at where the world is now in terms of understanding the challenges of dementia and of hearing the voice of people with dementia, we've made an immense amount of positive travel in the last 10 years. I think that with long-term care and what COVID has brought is, as people have said, an absolutely perfect storm that has revealed in a way that is unforgettable, I think, within countries, that is unforgettable what the limitations and the frailties of our current systems. And just because people haven't acted in the past, it doesn't mean that they won't act now. I think that we have reached a tipping point with respect to long-term care. And I think that this will become one of the issues politically. And once there's a political will, then there are a lot of ways to ensure that we make things better for people who live in long-term care homes. So I believe that we're at a tipping point, and that COVID has helped us to tip that over from inaction to action.
Well, let's hope you're right, and will be the silver lining in this awful pandemic. Now, Roberta, going forward, what gives you hope that we can fix this system for our elders?
What gives me hope is continued conversation. The fact that we do have all these research reports and documents that we can now firmly say, let's not keep, just talking about it, let's start doing it. In all honesty, at times my hope ebbs and goes away almost, and sort of what the point, but then remembering again, coming back to the individual and coming back to what it is that we can do in our own lives. And I do believe that it can hold on to hope, because it can make that difference in little bits at a time, and can sort of have the ripple effect. And I'm reminded of an expression that somebody back in my many years ago college university days said, "Don't run out of hope when you can't run out for more." And I don't feel I've run out of hope yet. And I do believe, to echo Sube's comments, we are at the tipping point, and I do think this tragically COVID-19 has made a difference and will continue to make a difference on long-term care for the positive, I hope.
And Sharon, the report Restoring Trust, it talked about a lot of problems, but it actually ended on quite a hopeful note. For those of us who read right to the end, it was quite hopeful.
Exactly, and I think that that all of us are really hopeful, and that we do see this as, as Shube said, a tipping point. And there's been momentum going forward. So the fact that we're having this conversation now, for example, I think is a tremendous sign of hope. The fact that a lot of the provinces have, restored and extended the pandemic pay, for example, for the long-term care home workers. The vaccines on the horizon, I think, is another hopeful strategy, and thinking and seeing the NACI guidelines where they're prioritizing, getting it out to the vulnerable populations. Things that have happened even, like at the provincial level, for example, in Ontario, the linkages between acute care hospitals and long-term care homes to provide the support on infection prevention and control. I would anticipate that that's going to be an ongoing relationship in the future, and I see that as a tremendous positive. In the engagement of the families and the essential care partners in this second wave of activity, I think has been a tremendous positive, and I would encourage even more of that going forward.
And Carol, we'll give you the final word. You said you were angry, but are you also a little bit hopeful as well?
Yeah, two things, Andre, give me hope. Although I have dark days, a lot of them. One is the problems, when you look at them in care homes, are imminently fixable. There's nothing here that's a dilemma that we can't fix. They're just so fixable, and we have a lot of good-hearted and smart people in this country and others who, if they're supported, can apply themselves. And the second thing is that I haven't talked to anybody in the industry, professionally in the industry, who doesn't care about the older adults in their care. And I haven't, there are always exceptions, but by and large, most long-term companions, families, and friends who have older adults in their sphere care about them. They care about them a lot, and they want the best for them. So if we can mobilize that desire to provide the kind of care Shube talked about and support, and look at these as simply problems that we can take a post, like we know we could take a post-World War II kind of let's rebuild and do this right this time attitude, and that sort of knowledge that of what we could do gives me hope.
Great. That's an excellent note to end on. Let's have a Marshall Project size response to our elders to fixing this system once and for all. So that's a great comment to end on. So I want to thank the audience, of course, for joining us. We could go on for another hour or two easily. There's a lot to talk about, but it's been a very thoughtful discussion. So please join me in thanking Roberta Bishop, Shube Banerjee, Carol Estabrooks, and Sharon Strauss for joining us today. And please keep chatting in the chat function for a bit, and thank you again for joining us, and until next time. Thanks, everyone.